Patient. The question is the patient has underwent extraction of mandibular molar so that he underwent multiple doses of local anesthesia. He later experienced itching, rash, and anaphylaxis. Now the patient here experienced allergic reaction. The patient experienced allergic reaction that includes itching, rash, and anaphylaxis. So this reaction, it is due to the, remember this is due to the IgE response. That occurs due to the IgE response involving immunoglobulin IgE. So when body is first exposed to allergen, here in this case, the allergen is component of local anesthetics. The immune system produces IgE antibodies specific to that allergen. So these IgE antibodies attach to the surface of the mast cells. So on subsequent exposure to the same allergen, the allergen binds to IgE antibodies that are present on mast cells. So this binding triggers the mast cells to release the chemical mediators. There would be release of chemical mediators like the histamine. And other mediators that are stored inside them. The release of these causes the symptoms of allergic reaction like itching, rash, swelling, and life-threatening complications. So answer is, therefore the answer is C, exposure by antigen by IgE, secondary response, mast cell, T granulation. Coming to the second question, the release a patient was on 20 milligram hydrocortisone for 4 years and he was advised tooth extraction. During extraction, he started experiencing lethargy, weakness, palpitation. The treatment was discontinued and he was prescribed 100 milligram of hydrocortisone. What is he being treated for? The answer is adrenaline insufficiency. Now, this condition occurs when the adrenal glands fail to produce sufficient amount of cortisol. So that we know cortisol, it is a hormone for stress response and maintaining the blood pressure, sugar level and metabolism. So hydrocortisone is a synthetic form of cortisol. The patient with adrenaline insufficiency are typically on long-term hydrocortisone therapy to replace the missing cortisol. So when a patient with adrenaline insufficiency undergoes stressful event, like here is the tooth extraction, that is the stressful event. The body requires a higher amount of cortisol to cope with the stress. So the symptom of lethargy, weakness, palpitation that are experienced by the patient during extraction, that indicates that the body is not receiving enough cortisol to manage the stress. So dosage here was increased from 20 milligram hydrocortisone to 100 milligram of hydrocortisone. So The dosage was increased to provide sufficient cortisol during the stressful event, that is the tooth extraction, and prevent an adrenaline crisis that can be life-threatening. So your answer is C. The symptom and treatment adjustment align with the managing adrenaline crisis in patient with the adrenal insufficiency. Coming to the next question. A patient with history of diabetes came to dental clinic for tooth extraction. While on chair, he experienced hypoglycemia and suddenly fall down with low blood pressure on dental chair. What would be your immediate treatment? So your immediate treatment here would be administered dextrose 50% IV. The patient who has history of diabetes experienced hypoglycemia. Hypoglycemia is, remember, hypoglycemia is low blood sugar. So severe hypoglycemia will lead to symptoms like fainting, confusion, seizures, and loss of consciousness, as well as low blood pressure. So these are the symptoms of the hypoglycemia. So dextrose 50%, it is a concentrated glucose that would provide immediate supply of glucose in the bloodstream. So this glucose in the bloodstream, it is commonly used in emergency situation to rapidly increase the blood sugar level. So that is why it is administered IV over 1 to 3 minutes to quickly correct the hypoglycemic state. Other options are lignocaine. Give lignocaine. Well, lignocaine is a local anesthetic and would not help in treating hypoglycemia. Normal saline and sodium chloride are not effective treatment for hypoglycemia as they do not provide glucose to raise the blood sugar level. That is why your answer is B. Coming to the next question. A 14-year-old patient has grossly decayed 3/6 which need extraction. Which treatment would you prefer to maintain space and restore function? The best treatment would be to use a removable partial denture. The removable partial denture is considered the most suitable answer among the given option, as this RPD can temporarily replace the extracted tooth. That helps to maintain space, restore function, and support proper chewing. So it is suitable for growing children and adolescents whose jaws bone are still developing. Implant, typically they are not recommended for patient at the age of 14 years as their jaw bones they are still developing. Implant requires stable and full developed bone structure for successful placement and long-term stability. So that's not the answer. No treatment required. This option is not advisable because leaving the space without any replacement could lead to drifting of adjacent teeth, loss of space, misalignment, and future ortho issues. Orthodontic treatment, it may not be the direct substitute for replacing the function of the missing tooth, especially in the younger children. So RPD is often initially used to prevent space loss until a permanent solution can be applied later. So answer is A. Coming to next question. A 50-year-old female visited a dental hospital with a complaint of pain after extraction of mandibular second premolar. She gave history for osteoporosis, exposed and necrotic bone in the socket that had persisted for more than 8 weeks, and no history of radiation therapy to the jaws. The condition was known as Brown's. What does Brown's stand for? It stands for, the answer is bisphosphonate related osteoradionecrosis of jaw. So the answer is both A and B. So Brown's stands for bisphosphonate related osteonecrosis of jaw. So it is a condition that is characterized by development of exposed necrotic bone in the jaw, typically occurring after dental extraction or other surgical procedure in patients who have been treated with bisphosphonate medication. So bisphosphonate, remember, it's a drug that are used to treat conditions like osteoporosis, bone metastasis, and multiple myeloma. So these medications are effective in preventing bone loss and reducing the risk of fracture in some cases. They can interfere with the normal bone remodeling process and impair the healing ability of jawbone. So Brown's is typically diagnosed based on specific criteria including the patient history of bisphosphonate, the presence of exposed and necrotic bone in oral cavity that has been persisted for more than 8 weeks. So your answer is Brown's. Coming to the next question. A patient with cleidocranial dysplasia was treated with extraction of all primary and supernumerary teeth and open surgical exposure of permanent teeth, all carried out as one procedure following by direct orthodontic traction is carried out for treatment of impacted tooth. Which of following approach was this? The answer is Toronto, Melbourne. It is a approach is a treatment protocol involving for the management of dental issues that are associated with the cleidocranial dysplasia. So the patient with cleidocranial dysplasia have delayed eruption of permanent teeth due to presence of retained primary and supernumerary teeth. Patient in CCD, cleidocranial dysplasia, the tooth are impacted and unable to erupt naturally. Open surgical assessing these impacted teeth by making incision in gums and sometimes removing the bone. So this procedure ensures that the permanent teeth are visible and accessible for orthotraction. The Toronto-Melbourne approach, it provides a comprehensive strategy for addressing the dental abnormalities that are associated with cleidocranial dysplasia. So this technique was named after Toronto, Canada and Melbourne, Australia, where the technique was developed. It is particularly effective in managing the complex dental cases. Coming to the next question. A 35-year-old patient required extraction of upper left molar, but since presented with exophthalmos and tremors and increased blood pressure. So which of following here could be expected? The answer is hyperthyroidism. B is the answer. Here the patient has exophthalmos. Exophthalmos means bulging eyes. the eyes that are bulging in appearance, tremors, and increased blood pressure. So that suggests hyperthyroidism. It is a condition where thyroid gland it becomes overactive and produce excess of T3 and T4 hormones. So T3, T4 hormones are in excess. Exophthalmos, it's referred to protruding eyes, and it is hallmark feature of Graves' disease, the most common cause of hyperthyroidism. Tremors, patient with hyperthyroidism experience tremors that are involuntary rhythmic. So that occurs because excess thyroid hormone increases the body metabolic rate that lead to increased nervous tissue sensitivity. Increased blood pressure, hyperthyroidism can cause cardiovascular changes including increased heart rate, blood vessel tone, resulting in elevated BP. Now the option A, hypertension, increased blood pressure, it is a symptom here. Hypertension alone does not explain the symptoms like exophthalmos, tremors. So that is why the answer is hyperthyroidism. Hypothyroidism, this condition is characterized by underactive thyroid factor and presence with the different symptoms such as weight gain, cold intolerance, and not exophthalmos, tremors, or increased blood pressure. Adrenal crisis, it is an acute condition that results from insufficient cortisol production, and it presents with symptoms like severe hypotension, abdominal pain, and confusion, not exophthalmos or tremor. So here the answer would be hyperthyroidism is your most commonly diagnosis. That is the answer of choice. Described condition in a 60-year-old female is osteoradionecrosis of jaw that is consistent with the patient's symptoms and the medical history. The osteonecrosis involves the death. It is a severe condition involving death of the jawbone, and it is associated with particular medications like the bisphosphonate that is used to treat bone-related conditions like osteoporosis, metabolic bone disease, and multiple myeloma. So the patient was on long-term bisphosphonate therapy for multiple myeloma that increased the risk of developing osteonecrosis. So the hallmark of osteonecrosis is exposed bone in the jaw that does not heal properly after extraction of oral surgery, leading to severe pain. Second is halitosis that can occur due to infection or necrosis in the affected area. There could be swelling, inflammation, and swelling are the most common due to the infection ongoing tissue breakdown. Apart from that, oral fistula could be seen, abnormal connection between oral cavity and skin, that is severe complication of osteonecrosis. So the answer is osteonecrosis here. Coming to the next question. A 50-year-old patient with a history of chronic alcoholism require multiple extraction. Which of following he would be prone to? The answer is increased PTT. Now, a 50-year-old patient with a history of chronic alcoholism is more prone to have increased PTT due to the liver dysfunction. Chronic alcoholism can lead to liver damage, such as alcoholic hepatitis, cirrhosis, or liver failure could be seen. The liver it play important role in production of various clotting factors that are necessary for normal blood coagulation. So when liver is damaged, its ability to produce these clotting factor is impaired. PTT stand for, remember, PTT stand for partial thromboplastin time. The measure the it measures the time it takes for blood to form clot via the intrinsic and common pathway. So in patient with the liver dysfunction, there is deficiency of the clotting factor, that are factor 8, 9 and 11, that can lead to increased PTT, indicating higher risk of bleeding. So while chronic alcoholism can be associated with pancreatic damage and diabetes, it is not a direct more result in this context. A decrease in PTT would indicate faster clotting, which is unlikely to occur in patients with liver disease due to the chronic alcoholism. Decrease INR. INR stands for International Normalized Ratio, that reflects the extrinsic pathway of coagulation. Liver dysfunction often leads to increased INR, not a decreased one. So the answer here is increased PTT. Coming to the next question. Person with known history of diabetes mellitus has been on medication for past 10 years and need surgical extraction of 3/8. What is the best way of managing such patient on day of surgery? The best way to manage patient with known history of diabetes mellitus who need surgical extraction of tooth is to follow dose of insulin and breakfast. So for diabetic patient, maintaining stable blood glucose level during surgery is important to avoid complication like the hypoglycemia, that is low blood sugar, or hyperglycemia. The recommendation is to have patient take their usually dose of insulin and eat breakfast before the surgery. So that helps to maintain a stable blood glucose level. Completely skipping insulin or going without food could lead to hypoglycemia, especially if the patient is on insulin or glucose lowering medication. So nothing by mouth. Considering standard protocols often involves nothing by mouth status to prevent aspiration, diabetic patient may require modification to avoid hypoglycemia. So avoid doubling or skipping the meals. Doubling the dose of insulin or doubling the quantity of breakfast could lead to dangerous fluctuation in the blood glucose level. So increasing insulin without increase in carbohydrate intake can cause hypoglycemia, and increased meal size can cause hyperglycemia. Skipping insulin and coming nil per oran can lead to hyperglycemia or diabetic ketoacidosis, especially in type 1 patient. So the ideal approach for managing a patient undergoing surgical extraction is to have them continue their usual dose of insulin and breakfast with modification as needed based upon timing of the surgery. Coming to the next question. A healthy pregnant woman came for extraction of lower wisdom tooth and she went into syncope. Which of following is the most common cause? The answer is the most common cause of syncope in a healthy pregnant woman during extraction of lower wisdom tooth is hypotension. So hypotension means low blood pressure. So during pregnancy, the body undergoes several physiological changes that can affect blood pressure regulation. The hormone level, there is increased level of hormones like the progesterone that cause relaxation of blood vessel, leading to vasodilation and potential hypotension. Although the blood volume increases, the vascular resistance it decreases, that can result in lower overall blood pressure. Change in body position like moving from lying down to sitting or standing can cause a drop in blood pressure. The term we use is orthostatic hypotension. So vasovagal response can be triggered by anxiety, pain, stress, leading to sudden drop in heart rate and blood pressure that causes fainting. So to prevent syncope during dental procedure in pregnant women, place the patient in semi-reclined to avoid compression of inferior vena cava that can exacerbate the hypotension. So the answer is hypotension here. A patient with iron deficiency anemia came for extraction of impacted wisdom tooth. Which of following contraindicate for such a procedure? So for such patient, hemoglobin level of 7 milligram per deciliter would be contraindication for elective procedures such as extraction of impacted wisdom tooth. The hemoglobin, we know it's a protein that is present in red blood cells that is responsible for transporting the oxygen from lungs to rest of body. Adequate hemoglobin level, they are important for maintaining oxygen delivery to the tissues and the organs. For adult male, the normal hemoglobin level is 13.8 and for females it is 12 to 15 milligram per deciliter. A hemoglobin of 7 milligram per deciliter below the normal range indicates the severe anemia. So with the hemoglobin level as low as 7 milligram, the body ability to carry oxygen to tissues is reduced. So patient with severe anemia have higher risk of complication during and after surgical procedure due to inadequate oxygen delivery to tissue that can lead to poor wound healing, increased susceptibility to infection, potential cardiovascular strain. So these are the outcomes. So your answer here would be 7. If a patient comes with history of cardiac problem, taking aspirin, what will be the possible complication if you do extraction? So aspirin is an antiplatelet medication commonly used in patients with cardiac problem to prevent blood clot and reduce the risk of heart attack. So how aspirin works? We know that aspirin, it works by irreversible inhibiting the enzyme that is COX irreversibly. So that is involved in synthesis of thromboxane A2. So thromboxane A2 promotes platelet aggregation and vasoconstriction. By inhibiting its production, aspirin reduces the ability of platelet to clump together and form clot. So during tooth extraction, oral tissues, the manipulation of oral tissue, the primary function of aspirin is to increase bleeding time because it inhibits the platelet function. This does not affect the parameter coagulation cascade like the prothrombin time, clotting time, or partial thromboplastin time. So your answer would be prothrombin time. So your answer would be increased bleeding time. Coming to the next question, patient with systemic lupus erythematosus and on corticosteroid therapy needs surgical extraction of tooth. What should surgeon instruct the patient? Now the answer is double the cortisone dose at the day of operation. That's your answer. Now, what is the reason for doubling the cortisone dose in lupus erythematosus patient undergoing tooth extraction? The patient with systemic lupus erythematosus on long-term corticosteroid therapy such as cortisone require a stress dose of corticosteroids during surgical procedure. So this is because the surgery induces physiological stress. Because the surgery induces physiological stress, which triggers the body to produce more cortisol. However, in patients on long-term corticosteroid, their adrenal glands may not produce enough cortisol to handle this stress. So, in order to handle the stress, so the long-term, the risk of adrenal insufficiency, the long-term corticosteroids use can suppress the body natural adrenal function. So, during stressful situation like surgery, there is risk of adrenal insufficiency. So it is a condition where body cannot produce enough corticosteroids to meet the increased demand. So the adrenal insufficiency can lead to complications such as low blood pressure, shock, or even death. Doubling the dose ensure that the corticosteroid level on the day of surgery is a common practice to provide adequate corticosteroid coverage during the surgical stress. So that helps the adrenal insufficiency and ensure that patient remains stable during procedure. So while doubling the dose might be the right approach in some cases, it is essential that this decision should be made in consultation with the patient rheumatologist or primary care physician. So that can your answer is double the corticosteroid dosage. Coming to the next question, which of following procedure regarding the patient who has been taking warfarin came to oral surgery for a procedure, which of following is not true about warfarin? The answer is INR of 3 is enough to start any extraction. So warfarin, we know warfarin, it is a common anticoagulant that reduces the risk of blood clot formation in a patient prone to thromboembolic events. So it work by warfarin, it work by inhibiting the synthesis of vitamin K dependent clotting factor that are 2, 7, 9 and 10 in the liver, affecting the blood ability to form clot. The INR, that is International Normalized Ratio, is standard measure to monitor the effectiveness of warfarin therapy. So it is based upon the prothrombin time that measures the time it takes for blood to clot. The INR allows for consistent interpretation of clotting time regardless of the testing method. So for most condition, a typical INR value is 2 to 3. However, the exact range can vary upon the indication for the anticoagulation. So INR of 3 might be appropriate for maintaining anticoagulation. In general medicine, it is not necessary for all dental procedures. INR of 3 is not safe. For invasive dental procedures like the tooth extraction, especially if the procedure is expected to be extensive with a higher risk of bleeding. So INR of 3 is enough to start any extraction is not true, because INR of 3 could still pose a bleeding risk for some dental procedure. For simple procedure, INR close to 2.5 might be more acceptable. So your answer is A. Other options affect the extrinsic pathway and increase prothrombin time. Warfarin inhibits vitamin K dependent clotting factor, thus affecting the extrinsic coagulation pathway and increasing the PT. Option C, heparin can be given subcutaneously and act rapidly. Well, heparin, it is a rapid acting anticoagulant that can be administered subcutaneously as a bridge when warfarin is temporarily discontinued. It takes at least 12 hours for vitamin K to reverse the action of coumarin. Vitamin K is used to reverse the warfarin effect, but it takes time, often more than 12 hours, to effectively restore the normal function. So that is why your answer is A, that is not true. Coming to the next question. Coming to the next question. A patient complains of stomach upset 48 hours after starting a course of antibiotic for severe pericornitis of lower impacted wisdom teeth. This is an example of side effect of the drug. So antibiotic, it is a side effect of the drug. Stomach upset after taking antibiotic, it is a side effect of the drug. A side effect is unwanted or unintended reaction that occurs in addition to desired therapeutic effect of medication. So side effect can range from mild to severe and vary from person to person. Antibiotic that are commonly prescribed to treat bacterial infection, including pericoronitis, that is inflammation of gums tissues around a partially erupted tooth, such as impacted wisdom tooth. While effective in treating infection, antibiotic can cause side effect, particularly related to GIT system. Stomach upset, including the symptoms of nausea, vomiting, diarrhea, is well-known side effect of many antibiotics. So these side effects occur because of antibiotics can disrupt the normal balance of bacteria in the gut, leading to GIT discomfort. Coming to the next question. A 40-year-old patient with persistent oral enteral fistula for 12 weeks period following extraction of maxillary first permanent molar is best treated by excision of fistula and surgical closure. So your answer is excision of fistula and surgical closure. An oral enteral fistula, we know it's abnormal communication between the oral cavity and the maxillary sinus, and occurs as a complication of following extraction of the maxillary posterior teeth, especially when the roots are in close proximity to maxillary sinus floor. So in this scenario, the patient has a persistent oral enteral fistula for 12 weeks following the extraction of maxillary first permanent molar. So when an oral enteral fistula persists beyond a few weeks, spontaneous healing is unlikely to occur, and conservative treatment like antibiotic, nasal decongestants alone are not ineffective. So oral enteral fistula that does not close spontaneously within short period are unlikely to heal without intervention. Continued, Continuous waiting would not address the permanent complication. So your answer is excision of the fistula. and surgical closure is the most appropriate and definitive treatment in that cases. So which of following is likely to occur if patient develops severe pain on second post-operative day of mandibular third molar dissection? Disinfection, the answer is dry socket. So dry socket, other name is, remember, alveolar osteitis. So it is a painful complication that can occur after the extraction of tooth, particularly mandibular third molar, and it occurs 1 to 3 days post-operatively, and it is seen second or third day after the procedure. After tooth extraction, blood clot usually form in the socket to protect the underlying bone and the nerves to facilitate healing. So in case of dry socket, this blood clot become dislodged or dissolved prematurely, resulting in exposure of underlying bone and nerve endings. So hallmark feature of dry socket includes severe throbbing pain that begins 1 to 3 days after the extraction. The pain is localized and it can radiate to other areas such as ear, temple, neck. So empty or partially empty socket upon examination with exposed bone viable. So the socket may appear dry and lack a protective blood clot. Apart from that, foul odor and bad taste in the mouth can result from exposed bone. Delayed healing can occur, can prolong the healing process. Option A, hemorrhage. Hemorrhage is excessive bleeding characterized by active or continued bleeding from the extraction site rather than the onset of severe pain on the second post-operative day. So option A is wrong, B is wrong, fracture of cortical plate is wrong. The answer is dry socket. Coming to next question, which is most common type of suture that we use in oral cavity? The answer is 3-0. So 3-0 suture is most commonly used. The sutures they are, remember, 1-0 suture and 2-0 suture, they are thicker and have a higher tensile strength. The 3-0 suture has moderate thickness and there is a balance between strength and fineness. 4-0, 5-0 sutures, they are thinner and more delicate. So in the oral surgery and dental procedure, 3-0 sutures, they are most commonly used. So this is due to their versatility and balance between strength and minimal tissue trauma. So that is why 3-0 sutures, they are more preferred. Coming to the next question. While removing an impacted wisdom tooth, if we have to do episectomy of the second molar also, which type of incision should be given? The answer is extended wart incision. So the answer is extended wart. So this one is the modified Wart's procedure. So this incision is preferred rather than the Wart's incision. So extended ward incision, it is the modification of ward incision. It starts similar at the distal aspect of second molar and extend more posteriorly upward along the external oblique ridge and provide a broader exposure that is needed to assess both the impacted wisdom tooth and the root apex of the second molar for episectomy. So this extended length allows for surgeon to create a wider flap and achieve the required visibility for both procedure. That is why your answer is modified wards incision. Coming to the next question. Crossbar and winter elevator work on the principle of wheel and axle. The answer is wheel and axle principle. So wheel that is attached to frontal axle, when a force applied to wheel creates rotational force that is transmitted to axle. So this arrangement multiplies the force exerted by the user. So answer is coming to next question. If patient comes with a history of cardiac problem taking aspirin, what shall be the possible complication if you do with extraction? So increase bleeding during dental extraction. The mechanical trauma to the tissue can cause bleeding. So in patient taking aspirin, the clotting process is impaired, leading to prolonged bleeding from the extraction site. So to manage the increased bleeding risk, dentists may use local hemostatic agents, apply pressure to the extracted site. So prothrombin time it is more affected by anticoagulants like warfarin, which are vitamin K antagonists. Aspirin primarily affect platelet functions rather than the clotting factor measured in the PT. Increased clotting time can be influenced by several factors, including clotting factors and anticoagulants, but the aspirin primarily effect is on
So,
bleeding
which
time
of following
due to its
method of
antiplatelet
sterilization is
action.
not effective as other technique? The answer is UV radiation. Remember that UV radiation is considered less effective for sterilization compared to methods like ethylene oxide, gamma radiation, or autoclaving. Remember ethylene oxide. Option A, it is used for sterilizing heat sensitive heat sensitive materials. The gamma rays, it is useful for sterilizing disposable medical equipment and pharmaceuticals. The autoclaving, it is a high pressure. Remember, it's a high pressure steam to achieve through sterilization. Effective against a broad range of microorganisms, including the spores. So your answer would be here would be C. Coming to the next question. In winter classification, the white line tell us the in winter classification, remember the white line would tell us. So is the this one is the white line. This region represents the amber line, and this one is the red line. So the white line represents the radiographic boundary between the impacted tooth and adjacent structure that helps in assessing the angulation of the tooth. So your answer is here is so your answer is angulation. Coming to the next question, during extraction of 1617 root stump was broken and procedure was instituted to remove the roots. But as soon as root was received, bubbling for the socket was seen. Communication with the maxillary sinus was inferred. What is the best treatment for accidental oral anal communication like this one during extraction, which is around 0.5 mm in size? Now it's saying that the size is, it is telling us that the size is 0.5 mm. The size is 0.5 mm in size. So for small oroantral communication around 0.5 mm, that is in size, the periodic observation and follow up are usually sufficient. So the small size of communication allow for natural healing patient provided the patient avoids activity that could disrupt the process. So if complication or communication does not close on it on more invasive procedure like buccal or palatal flap technique may be used. So your answer is C. Now coming to the next question. A patient required tooth extraction from area that has been subjected to radiation therapy. Which of following represent the greatest danger to the patient? The answer is osteoradionecrosis. Answer is osteoradionecrosis. It is, remember, it's the most significant risk for patient who has undergone radiation therapy in the head and neck region, particularly when undergoing procedures like the tooth extraction. The, so the compromised blood supply and impaired healing in irradiated tissue makes them highly susceptible to this condition. So proper management and careful planning are essential to minimize the risk and complication in this patient. Coming to the next question, which of following will be correct for hypertensive patient receiving LA with adrenaline? So the adrenaline injected with LA is less harmful than its endogenous product. Now, this is generally accurate. In local anesthetic formulation, the concentration of adrenaline it is quite low compared to what body produces naturally during stress. So, question A, it's a absolute contraindication. Adrenaline is not an absolute contraindication in hypertensive patient, but it is, but caution is advised. Second, it causes peripheral pooling of blood leading to increased risk of hypertension. This is not correct. Adrenaline in local anesthesia causes vasoconstriction. which reduces bleeding and does not lead to peripheral pooling of the blood. Option D, adrenaline will increase the heart rate by activating the parasympathetic system. This is incorrect. Adrenaline stimulates the sympathetic nervous system, leading to increased heart rate and blood pressure. So your answer is B. Coming to the next question, in which of following given patient clinical scenario who will undergoing a dental extraction assessment of coagulation status is not considered as primary concern in an investigation. So for patient with a recent viral hepatitis, a history of stroke with antithrombotic therapy, or those on long-term carbamazepine therapy, assessing coagulation status is more critical due to long potential risk of bleeding or interaction with medicaments. So in context of dental extraction, bronchial asthma typically does not require a primary focus on coagulation status unless there are additional risk factor concern. The main focus for the asthmatic patient is usually on managing their respiratory condition and ensuring that asthma is that the asthma it is well controlled before and during the procedure. So your answer is bronchial asthma here. Coming to the next question, the patient after dental extraction showed an immediate reduction in bleeding but continued to bleed in small amounts for the whole day. Which of following investigation will be most appropriate? So, bleeding time is the most appropriate initial investigation. Bleeding time assess the primary hemostasis, specifically the platelet function. And the vascular response to injury. So it is useful for assessing conditions that affect the platelet function or initial clotting process. The INR, remember it measures the time it takes for blood to clot, and it is used to monitor patient on anticoagulant therapy. It is more related to secondary hemostasis. Clotting time, it measures the time it takes for blood sample to clot in a test tube. It is less common used today due to its variability. Platelet count, it gives information about number of platelet but does not assess the platelet function directly. Coming to the next question, drug which need certain adjustment and specific management before and during dental procedure are steroids do require special management in context of dental procedure due to their effect on the adrenal function, immune suppression, and wound healing. So your answer is steroids. Coming to the next question, management of dry socket includes all of the following except in management of the dry socket, aggressive curettage of socket is generally not recommended. So your answer is A. Use warm well saline to flush out debris without aggressive curettage. That is correct. Place a sedative dressing like diodoform or eugenol based packing to protect the exposed bone and soothe the area. That is also correct. Prescribe analgesic to manage the pain and discomfort. Antibiotics they are generally not indicated unless there is evidence of infection. The key is to avoid aggressive measures that could further irritate the site and focus on gentle care and symptom management. Coming to the next question, severe pain in dry socket is due to the managing dry socket involves addressing the pain and protecting the exposed bone to promote healing and alleviate discomfort. Remember kinins, these are the inflammatory mediator that cause vasodilation and increase the permeability of blood vessel, leading to pain and swallowing. So they are relieved as a result of tissue trauma and contribute to pain that is experienced in dry socket. So other factor contributes to pain in dry socket includes exposure of nerve endings, the bare bone and exposed nerve ending in extraction socket. They are sensitive to stimuli such as air, food and fluid. Infection. While infection can complicate the condition, the primary source of pain in dry socket is due to inflammatory mediators like the kinin. So your answer is kinin. Coming to the next question, intake of which of following lead to increase incidence of uh, dry socket? The answer is oral contraceptive. Now remember the factors that has an increased risk are number first is oral contraceptives, hormonal changes caused by oral contraceptive can affect the clotting mechanism and healing of the extraction socket. Second is smoking. Smoking can interfere with the blood supply to extraction site and hinder the clot formation. History of pericoronitis. Previous inflammation around the partial erupted tooth can make the socket more susceptible to dry socket. Traumatic extraction that causes significant trauma and performed by less experienced practitioner can increase the risk. Last is the inadequate irrigation. Failure to thoroughly rinse and clean the extraction site can lead to debris and potential complications. The factors that decrease the risk are chlorhexidine mouthwash. Rinsing with chlorhexidine mouthwash can help us to reduce the bacterial load and decrease the risk of infection. Good oral hygiene perioperatively, maintaining excellent oral hygiene before and after procedure help in relieving the risk of complication. Coming to the next question, how can you diagnose a dry socket patient? Now, the diagnosis of dry socket is primarily made through the clinical examination. So, patient often reports severe pain that typically starts a few days after extraction. The pain is usually intense and not adequately relieved by the over-counter analgesics. So, the extraction socket may appear empty or show partial blood clot that is dislodged or absent. Halitosis may be seen, delayed healing. So the patient, so the answer is clinical examination. Radiographs are typically not necessary for diagnosis dry socket. They may be used if there is need to rule out other condition or a complication. The patient history can provide essential clues such as onset of severe pain a few days post extraction that aligns with the typical dry socket symptom. So the primary diagnostic tool for dry socket is the clinical examination, complemented by patient history and, if necessary, radiograph or other tests to exclude other conditions. Coming to the next question, dry socket, which of following is statement is true? Dry socket, we know that it is also known as alveolar osteitis. It is a painful condition that occurs after tooth extraction when blood clot that normally form in the socket is lost or fail to form properly. So this blood clot is essential as it protect the bone and nerve ending in the socket, facilitate healing and prevent the infection. So while inducing bleeding to encourage clot formation can be a step in managing a dry socket, it is not a primary treatment focus. The primary treatment focus involves cleaning the socket and applying medicaments, medicated dressing to promote healing and reduce the pain. So that is why your answer is D. Dry socket is not classified as form of osteomyelitis. Osteomyelitis is infection of bone, whereas dry socket is an inflammatory condition without infection. Dry socket is more common in the posterior teeth. It is associated with extraction of mandibular posterior teeth, particularly the third molar, rather than the anterior teeth. So it results from the loss of blood clot in the socket. That's the accurate statement. The dislodgement or dissolution of blood clot exposes the underlying bone and nerve endings, leading to pain, inflammation, and delayed healing. Coming to the next question, the main factor that is responsible for destruction of clot leading to dry socket is the answer is the plasminogen. The primary factor responsible for destruction of blood clot leading to dry socket is enzymatic breakdown of fibrin within the clot that involves activation of plasminogen into plasmin. And this process is catalyzed by an enzyme that is known as fibrinolysin produced by bacteria. So plasminogen is an inactive precursor protein that when converted to plasmin become active enzyme involved in fibrinolysis, that is the breakdown of fibrin. So in the context of dry socket, bacterial fibrinolysin can activate plasminogen to plasmin leading to degradation of fibrin matrix. that stabilize the blood clot. Option second, fibrinogen. It is a soluble protein that is converted by thrombin into fibrin during blood clot formation, and it is not directly responsible for clot breakdown. Actin Actin is a protein that is involved in cellular structure and muscle contraction, and it is unrelated to clot formation or breakdown. Fibrin is an insoluble protein that forms the mass structure of the blood clot. While fibrin is a substance being broken down in dry socket, it is not the factor that is responsible for destruction. The enzymatic breakdown facilitated by plasmin is the cause. As per Nijin theory, the microorganism that are responsible for dry socket is the Treponema. Treponema denticola, with its potent fibrinolytic activity, can disrupt the integrity of blood clot formed in the extraction socket that leads to dry socket. So dry socket is a painful condition that can develop after tooth extraction, occur when the blood clot that normally forms in the extraction site is dislodged. So the main prominent feature of dry socket is severe continuous or nearly continuous pain that is often radiate to ear, temple or neck. So answer is Treponema denticola. So dry socket is characterized by the answer is B. Remember that the dry socket or alveolar osteitis, it is common complication following tooth extraction that is characterized by a continuous or almost continuous pain. The most prominent symptom of dry socket is severe continuous or nearly continuous pain that begins few days after extraction. The pain can radiate to ear, temple, neck, and it is described as throbbing or aching. Unlike other post extraction complication, a dry socket does not involve significant swelling of the surrounding tissue. Swelling is, if present, is usually minimal as compared to other conditions like the infection or hematomas. So in dry socket, the extraction site appears empty or partially filled as the blood clot that normally forms and protects the socket is dislodged or dissolves prematurely, exposing the underlying bone. Other options, episode of sharp piercing pain associated with sweet foods that is not the characteristic feature of dry socket. Continuous bleeding from socket with swollen gingiva. They are more indicative of infection or hematoma rather than dry socket. Indurated swelling with local tenderness and temperature. This presentation is typically more of infection or abscess and not of dry socket. So your answer is B. Coming to the next question. Coming to next question. A 32-year-old man comes to you on third day after extraction with severe pain. The most common cause would be dry socket. So remember that dry socket usually develop 3 to 5 days after the extraction. It usually occurs 3 to 5 days after the extraction, and there is severe throbbing pain in the site due to loss of blood clot that normally forms in the socket. So this, coming to the next question, the came to your clinic and noticed there is dry socket following extraction of tooth, the reason could be disintegration of blood clot. So the answer is disintegration of the blood clot. So dry socket, we know it occurs when the blood clot that forms in the extraction site is dislodged or dissolves prematurely. So the dry socket is caused by premature disintegration of blood clot within the socket. So that is due to increased fibrinolytic activity where the clot is broken down by enzyme leading to exposure of bone and nerve endings. So the disintegration can be triggered by various factors including bacterial activities or trauma during or after the extraction. Other options, while bacterial infection can occur after extraction, Staphylococcus is the primary cause of the dry socket. Dry socket is not an infection but an inflammatory condition that results from loss of blood clot. The prolonged use of antibiotic is not related to cause of dry socket. Antibiotics are typically used to manage or prevent infection but does not influence the formation or stability of the blood clot in the extraction socket. So your answer is disintegration of the blood clot. Coming to the next question, a patient having history of myocardial infarction is on bi-anticoagulant therapy of aspirin 150 milligram and clopidogrel 75 milligram need extraction. Which of following is correct here? The answer is refer patient for BTCT and do extraction based on range of BTCT. So for patient on anticoagulant therapy such as aspirin and clopidogrel, it is important to manage the risk of bleeding during dental extraction. So refer the patient for BTCT and do extraction based on the range of BTCT. So that approach ensures that the bleeding and clotting status of patient is assessed before proceeding with the extraction. So that helps in planning the procedure with appropriate measure to control bleeding and minimizing the risk. So this might include a special hemostatic technique, adjustment to the procedure, or the use of local hemostatic agents. Coming to the next question, repeated repeated inferior alveolar nerve blocks were administered to patient for extraction of impacted mandibular third molar. 2 days later, he reported back with the trismus. The most commonly cause could be the answer would be injury to medial pterygoid muscle fibers. Remember that trismus or limited mouth opening can occur following dental procedure, especially those involving multiple injections. The medial pterygoid muscle is one of the muscle involved in mastication. It can be affected by repeated injection of local anesthesia, which might penetrate the muscle and cause inflammation and trismus. The other options are less likely in this context. Fracture of angle region of mandible, it is the less common cause of trismus in immediate post-operative period unless there was significant trauma during the extraction. That is not usually the case with the standard extraction. Infection can lead to trismus that typically present with additional signs like fever, swelling, and possible pus that would develop later if infection is caused. Injury to the temporalis muscle can be this muscle can be involved in mastication. It is less common affected by injections compared to medial pterygoid. Coming to the next question, Which of following maneuver can significantly decrease the incidence of post extraction dry socket? The answer is copious saline irrigation under pressure after the extraction. Dry socket can be mitigated by various measures, but copious saline irrigation under pressure they are particularly effective. Thorough irrigation of the extraction socket with saline delivered under pressure helps to remove the debris and minimize the bacterial contamination that can reduce the risk of dry socket. So that this practice help to ensure that bound area is clean and reduce the chance of premature clot disintegration. The other options, antibiotic can help in preventing infection and analgesic can manage pain, but their direct effect on reducing dry socket is less significant compared to proper wound management and irrigation. Cold pack, applying a cold pack can reduce the swelling and pain but does not directly affect the incidence of the dry socket. Biting onto tea bag after extraction, it is a common home remedy used to help with clot formation. It can aid in clot stabilization as it is not effective as thorough irrigation in preventing dry socket. Coming to the next question, which of following hemostatic mechanism extraction socket can result in delaying in healing of socket? So the answer is oxidized regenerated cellulose is the one that can potentially lead to delay in healing of the extraction socket. Oxidized regenerated cellulose is a hemostatic agent that can help to control bleeding from extraction socket. So there's that acts by promoting clot formation. However, it can sometimes lead to delayed healing due to its nature. The cellulose material can be slow to dissolve and may interfere with the natural healing process, potentially leading to longer healing time compared to the other material. Sponge, it is commonly used for hemostasis and provides a scaffold for blood clot formation. Figure of 8 suturing it. This technique helps cure the blood clot or hemostatic material in place, supporting proper healing by maintaining closure of extraction site. It does not cause delay in healing. Tannic acid, it is another hemostatic agent that helps in clot formation and does not generally result in delayed healing. So among the option provided, oxidized regenerated cellulose is the one that can potentially lead to delay in the healing of the extraction socket. Coming to the next question, which of following statement about the flap designing is incorrect during open method of extraction? The answer is the incision placed to reflect the flap always heal along its length and shorter incision is preferred. So in flap design for open extraction, remember that the base of flap should always be wider than its apex. So that ensure a better blood supply to the flap and promotes its adequate healing. The healing process occur along the incision rather along the length. Long straight incision with proper flap reflection usually heal better and faster compared to the shorter ones. So the summary is to avoid short torn incision and prefer longer straighter incision with adequate flap reflection to ensure better and faster healing. Post tooth extraction gauze should be placed for hemostasis. What is the recommended method of placing the gauze. It should take place so after tooth extraction, gauze is placed to control bleeding and promote hemostasis. The recommended method for placing gauze is to by positioning the gauze in space where the tooth crown was and having the patient bite down on it. Pressure is applied directly to the extraction socket. This pressure helps to promote clot formation and control bleeding more effectively. While performing extraction of tooth with forceps, the first apical force applied will help in moving the center of rotation of the tooth more apically. Applying apical forces with the forceps helps to expand the tooth socket by inserting the beaks into the periodontal ligament space. So this pressure moves the center of rotation apically, which facilitates further movement and extraction of the tooth. So answer is A.